Shall we start?
Sir, we can start, sir. Murida sir will be joining shortly, sir.
All right. Okay.
Yes, sir.
All right. So, good evening, everybody. So, on behalf of the Forum of Cardiac Anesthesia, Bangalore chapter, I invite everyone to another session where we will be discussing about new developments in the field of cardiac anesthesia and critical care. So, today we have a very interesting topic that is basically about leadless pacemakers. So as we all know, traditionally, pacemakers have been the standard treatment option in patients with severe or symptomatic bradycardia. And the traditional pacemakers, they require a surgical pocket to be created under the skin to keep the generator, and also a set of transvenous leads that go and attach to the heart and to do the pacing. But pacemaker technology has undergone significant advancements since the time it was introduced in 1958. So right now we are seeing more and more devices, basically the leadless pacemakers, where the requirement for a transvenous lead to attach to the heart has been done away with. So these are 90% smaller than the traditional transvenous pacemaker, and it is a self-contained generator and electrode system that is directly implanted into the right ventricle. So the advantage of this system is that it does away with the several complications associated with creation of a surgical pocket. So the complications like pocket infection, hematoma, all those are done away with. And there are no transvenous leads as well. So the complications like lead dislodgement, lead fracture are also done away with. And also there is a better cosmetic appeal with this device because there is no skin lesion or skin incision that is done to implant the paceless pacemaker. So keeping all these space advantages in mind, so it is only natural to think that these devices are only going to become much more common in the days to come. So with such advancements coming up in the future, it is only natural or imperative for the anesthesiologist to be well versed with these advances in technology. So to enlighten us about this particular feature, I invite Dr. Kedar from NH to give us a briefing about the leadless pacemakers, and as an anesthesiologist, how will we manage a patient with a pacemaker, with leadless pacemaker. So Kedar, over to you.
Yes, sir. Good evening, one and all. Am I audible?
Yes, Kedar, you're audible.
Okay, thank you, sir. Good evening, one and all. I am going to speak about non-transvenous cardiac implantable electronic device technology, a review for the anesthesiologist. So it is a frequent occurrence that a patient has some conduction abnormality present. I mean, there are there are a large number of patients having bundle branch blocks and other conduction abnormalities normally also and after any surgical procedure done on the heart. So it is a very common procedure that they undergo permanent pacemaker implantation, and we all are familiar with how to manage a permanent pacemaker. A patient coming with a permanent pacemaker perioperatively. But the issues are well known, like lead dislodgement, lead fracture, and after that the patient, there is a catastrophe. Patient goes into a heart block and rest of the things. So now the upcoming technology in pacing is of leadless pacemakers. So as the incidence has been given here is of American incidence. Approximately 1 million people are undergoing CIED implantation worldwide. There is an annual increase in this number. The traditional approach was transvenous CIED implantation, and it was having many complications like pneumothorax, lead dislodgement, cardiac perforation, vascular injury, and late complications were thrombosis of central vein and obstruction, lead related complications, pocket infection and erosion, and lead related endocarditis. So the manufacturers have decided to go towards production of non-transvenous CIED. Another factor is that these non-transvenous CIEDs are totally new in this medical field, and as I discussed earlier, there is no known guideline given by American Heart Association or Heart Rhythm Society regarding perioperative management of patients with these devices. So there are ongoing trials. So as of March 2017, 1,423 patients had NanoSteam device. NanoSteam is a company, a brand name of leadless pacemaker. 1,423 patients had this device. Then when enrollment to the MICRA TPS registry was completed in May 2015, 719 patients had successful implantations. So MICRA is another company, another device that is based in Boston, USA. An ongoing MICRA post-approval registry. They are conducting a prospective and non-randomized study to evaluate the safety and efficacy of MICRA TPS. They also intend to enroll this large number of patients. At present, there are no AHA or Heart Rhythm Society guidelines, as I have told. So the aim of the current study is to review the current US FDA approved non-transvenous CIED technologies to discuss the perioperative management of patients with these devices in situ. So commercially available non-transvenous CIED technologies are as follows. They are approved by FDA and they are called leadless pacemakers and defibrillators. But they can either defibrillate or pace. They cannot do both. So leadless pacemakers are implanted under fluoroscopic guidance and are anchored within the right ventricle endocardium. After that, they undergo a fibrous capsule formation around them, and then hence they are not, they don't move anymore as they undergo endothelialization in the heart. So defibrillators are implanted in the extrathoracic region that sense, detect, and defibrillate malignant ventricular tachyarrhythmias. That is, defibrillators will have pulse generator in the extrathoracic region and the device will be in situ in the heart. So coming to leadless pacemakers, there are two varieties, MICRA AV, which has AV, that is atrioventricular synchrony, and MICRA VR. MICRA VR has got only one device implanted in the right ventricle. And the third one is NanoSteam. The manufacturer is different. This device is under investigation because there is battery depletion, docking, attachment problems, but it is approved in Europe. So MICRA belongs to Boston-based company. It treats bradyarrhythmias by providing right ventricular endocardial pacing, sensing, and pacing rate modulation. It's approved by FDA in 2016. It is feasible, safe, and effective alternative to transvenous CIED. So as we can see, the MICRA device looks like this. It is implanted internally in the right ventricle, as we can see in the image on the right side. On chest X-ray, we can see the implanted devices. The arrow points to the MICRA device. So, implanted by transfemoral venous approach in the right ventricle endocardium and attaches there by means of 4 nitinol tines. That is, it has got 4 hook-like things, which we can see here in this image. The device has got 4 hooks. So it implants with the help of these hooks. MICRA VR is a single chamber pacemaker that only does right ventricular pacing with the help of accelerometer, which detects the motion. They do not provide anti-tachycardia pacing, defibrillation, and atrioventricular synchrony. So if a patient is having tachyarrhythmia, they are of no use. Battery life is 12 years, implanted by transfemoral and transjugular venous approach. Size is 2.6 by 0.7 centimeter, and 23 French introducer sheath is required. Programmers are of CareLink, Encore, and CareLink 2090. These are the softwares. And standard pacing modes are VVI, VVIR, VOO, OVO. MICRA AV is FDA approved. Pacing modes are VVI, as I discussed all these pacing modes. The added feature in MICRA AV is AV synchrony pacing. It improves biventricular stroke volumes. MICRA atrial tracking using a ventricular accelerometer to trial has shown the increased efficacy of MICRA AV. It relies on accelerometer for knowing atrial myocardial strength, and hence the effectiveness of MICRA AV synchronous is reduced. Because it depends on accelerometer. If accelerometer shows that there is motion or less motion, only then it will pace. MICRA AV, again, activity mode and AV conduction mode. Two kinds of modes are there. In activity mode, it changes from the synchronous VDD mode to VDIR, that is AV non-synchronous mode, when it detects any increased right atrial contractions and switches back to VDD on completion of intensive activity. It increases pacing rate when metabolic demand increases. In AV conduction mode, it facilitates AV conduction in cases of sporadic AV conduction blocks. It changes from V dual to VVI at 40 beats per minute when heart rate reduces, and suspends pacing when heart rate normalizes, hence increasing longevity of the device. In the long term, there are some cons of this device. The disadvantages are that there will be left ventricular dysynchrony and left heart failure. This is because MICRA device is only pacing the right ventricle, but it has got no connection with the activity of the left ventricle. So there may be an abnormality in the left ventricular activity sometimes, and it will lead to dysynchronous behavior. So the both ventricles will not be in synchrony, and there will be reduction in the cardiac output, leading to left heart failure. Electromagnetic interference is an issue. The sources of electromagnetic interference are electrocautery, transcutaneous electrical nerve stimulation for postoperative pain, electroconvulsive therapy, radiation therapy, magnetic resonance imaging, and extracorporeal shockwave lithotripsy. Anesthetic considerations. Applebaum et al. Have published ASA practice advisory concerning CIED perioperative management. Detailed preoperative assessment, type and site of surgery, type of MICRA device, indications of placement, current device settings, and degree of pacing dependence, etc. need to be known. In MICRA devices, magnet cannot be used and requires reprogramming as done by Karupia et al. The actual issue is that when we place the magnet on the chest wall, on the skin surface, it is not going to be effective. A magnet can only work if it is directly placed on the apex of the heart. For that purpose, sterile magnets are available. In the study done by Karupia et al., he has left the MICRA device in VVI pacing mode during the surgery, and he has observed that the cases were done uneventfully. Electromagnetic interference can be avoided by placing the grounding pad in such a way as to avoid the passage of current through the MICRA, and use of bipolar cautery is recommended. So these things we already do in a permanent pacemaker patients which are present currently. So this is not any new guideline. As I said, there are no new guidelines as of now. So anesthetic considerations again. Asynchronous pacing may cause ventricular fibrillation due to R1T phenomenon and hence should be avoided. VVI mode is suitable during surgery with the use of bipolar cautery or very short duration of use of monopolar cautery. Within a few months of implantation, MICRA may get embolized due to PA catheter insertion or due to right ventricular support devices like Impella. In a case series by Gifford et al., the author has reported no EMI or device malfunction with MICRA in VVI mode. The NanoStim LP has an option to program the device to have the magnet mode turned on or off. Once the magnet is detected, the device will switch to VOO mode. It will become asynchronous. When the device detects a magnet, the device paces asynchronously at a rate of 100 beats per minute for 8 cycles, then at 90 beats per minute. NanoStim LP contains an EMI reversion mode that allows the device in the presence of continuous EMI presence in the R-wave sensing channel at a frequency of more than 16 Hz to convert to a VOO mode at an interference pulse rate until the noise ceases. Means whenever there is interference, the device will become asynchronous. So these are the guidelines which we have to follow in case we are not able to do reprogramming of the device before surgery. Normally what we do is that we call the pacemaker team to do the reprogramming, or we consult cardiologist or electrophysiologist. But in case if that is not possible, or if the surgery is too emergency, then we can go ahead with these guidelines. Temporary pacing and defibrillation equipment in the operating room should be available. Brief surgeon about the unique pacemaker and device, and advice to use a bipolar electrocautery system or harmonic scalpel. If a bipolar electrocautery system is not available, then position the return electrode patch such that electrical current pathway does not pass within 15 centimeter, that is 6 inches of the device. Use short, intermittent and irregular bursts at the lowest clinically appropriate energy level. Intraoperative monitoring. Consider manually monitoring the patient rhythm, that is, take the pulse by palpation. Consider monitoring the patient by some other means such as ear or finger pulse oximetry, Doppler pulse detection, or arterial pressure display. Post-operatively, consider post-operative interrogation of the device again. If monopolar cautery was used, if patient is hemodynamically unstable, and after cardiothoracic surgery, if radiofrequency ablation or external cardioversion was done. So this is the transfemoral implantation of MICRA in the right ventricle. It has attached itself with the hooks. So coming to another type of device, that is S-ICD. S refers to subcutaneous, that is, it is implanted subcutaneously. A trial was published in New England Journal of Medicine that found that S-ICD are non-inferior to transvenous TV ICD. Patients who are young have a risk of infection or a difficult vascular access. Patients not expected to receive bradycardia or CRT are suitable for S-ICD implantation. In 2017, AHA, ACC and Heart Rhythm Society guidelines have listed S-ICD implantation as a class 1 recommendation for above mentioned reasons. The contraindications are anti-tachycardia pacing, bradycardia pacing and CRT. So in S-ICD there is going to be a pulse generator, as we can see on the left part of left anterior part of the chest wall. It has it connects with the wire or lead with the device. So components of S-ICD, there is a pulse generator, single subcutaneous lead containing high voltage and low impedance shock coil and 2 sensing electrodes. Pulse generator is implanted subcutaneously or intramuscularly between serratus anterior and latissimus dorsi muscles along the left mid-axillary line. The pulse generator is connected to a single subcutaneous lead tunneled along the left parasternal border. SQRX received FDA approval in 2012. Currently, Emblem MRI is the ICD, S-ICD in its third generation, and it's being manufactured. Emblem MRI can deliver up to 5 non-programmable shocks of 80 joules per second per episode, to treat malignant ventricular tachycardia and ventricular fibrillation. There is no anti-tachycardia pacing therapy. As I said earlier, a defibrillator will not pace and a pacer will not defibrillate. So there is no anti-tachycardia pacing therapy and sustained bradycardia pacing capability. There is only a provision of 30 seconds of post-shock bradycardia demand pacing at 50 beats per minute for bradycardia less than 50 beats per minute. The manufacturers are currently developing a modular leadless device that can communicate with the S-ICD and can also deliver ATP. This is the Emblem MRI S-ICD device. So anesthetic considerations, a CIED team member or an electrophysiologist should be consulted to interrogate the S-ICD. The device interrogation reports should be accessed for information on reprogramming the device by magnet for shock suspension and enabling shock therapy mode. Transcutaneous defibrillator should be available for immediate defibrillation, life-threatening ventricular arrhythmias and unnecessary shocks by S-ICD should be avoided as it may lead to ventricular fibrillation. EMI will induce shocks and it can be suspended by a magnet or by programming them off. After magnet is applied, the beeping tones are heard that are synchronous for R wave and will end after 1 minute. Only after these tones are heard, it can be assumed that the magnet has done its job and the shock therapy is disabled. If the tones are not heard, the shock therapy is still on. Defibrillator pads should avoid the pulse generator to avoid any damage to the S-ICD. The electric current return path should avoid the S-ICD sensing region, that is left anterior chest wall. So the non-transvenous CIEDs that are under investigation are wireless biventricular cardiac resynchronization therapy, that is WISE CRT in short form. So it is indicated in patients with less than 35% ejection fraction due to interventricular conduction abnormalities like left bundle branch block or broad QRS complex, requires right atrial and right ventricular leads and coronary sinus lead to pace the left ventricle. WISE CRT, wireless stimulation endocardially, uses endocardial electrode placed transfemorally retrogradely in the posterior or posterolateral wall of the LV and controlled by ultrasound. So here we are placing it through femoral artery. Earlier devices were placed through femoral vein. So this is the WISE CRT. First, it will detect the RV pacing pulse from the co-implant, which we can see in the box numbered as 1. Then it will transmit ultrasound energy to the receiver electrode, which we can see below the positioned below the heart. And receiver electrode paces converting the ultrasound energy into the electrical energy. So non-transvenous CIEDs under investigation. Continued. The battery and transmitter that communicates ultrasonically with the electrode are implanted in the left chest wall. This system works in conjunction with the RV pacemaker to pace the LV in synchronization with the RV. Perioperative guidance regarding WISE CRT is lacking, but conventional approaches like applying magnet to make asynchronous RV pacing will also make LV pacing asynchronous. Similarly, EMI will inhibit WISE CRT, RV pacing and LV pacing alike. Coming to the another type of device, modular pacing, that is combining pacing and defibrillation therapies. FDA approved non-transvenous CIEDs like MICRA AV and MICRA VR lack tachyarrhythmia therapy and provided independent RV pacing only. S-ICD provides defibrillation only of malignant ventricular arrhythmias but no pacing. They do not communicate with each other and do not provide synchronized therapies. So manufacturers of Emblem S-ICD, which we have discussed now, have designed Empower Leadless pacemaker communicating wirelessly with Emblem S-ICD. So this is the Emblem device, which is an S-ICD. So when combined with these two devices, they can deliver anti-tachycardia pacing and bradycardia pacing done by Empower, and also can provide defibrillation done by Emblem S-ICD. So Tong et al. Has shown that demonstrated in the study that they are having feasibility, safety, and efficacy of modular device therapy using Empower Leadless pacemaker and Emblem S-ICD. Human trials are not yet complete, and hence the authors have not commented on the anesthetic management of these devices. So in conclusion, transvenous CIED have increased cost, morbidity, and mortality. Non-transvenous CIED have safety, feasibility, and efficacy as an alternative to transvenous pacemakers. Leadless pacing technology is in the second generation and is improving in providing AV synchronization as seen in MICRA AV, and S-ICD technology is in third generation in developing the ability in providing compatibility with leadless pacemakers. Anesthesiologists should become familiar with the features of these devices and should learn the technique of to manage them. Formal practice guidelines do not exist. A detailed patient history, understanding of the indications for pacing or defibrillation, the type and setting of non-transvenous CIED pacing dependency, and location of surgery should guide the perioperative management. Consultation with the cardiologist and a dedicated CIED team member should be done. Thank you.
Thank you, Kedar, for that wonderful presentation. So it's a very nice presentation of what the future holds for us with relate to pacing technologies. So as Dr. Kedar has rightly pointed out, so these devices are in the phases of development and not very long in the future. We will be facing patients with these devices in situ. So it is only imperative that we have to know about these technologies, and when we are faced with a patient like this, how do we go about caring for them? So Dr. Kedar has nicely delineated those technologies that are existing and also the devices that are under investigation. And also, since there are no practice guidelines at the moment, but just a few case reports of from institutions that have used these devices are the only ones that are available in literature at the moment. So as more evidence comes out, hopefully we will have practice guidelines from reputed organizations that will give us more details about how to manage these devices. Till then, it is these, as Dr. Kedar has outlined, it is these guidelines only that we have to take going forward. So with that, I open the forum for discussion and invite all participants to participate in the discussion and also post your questions. Either you can unmute yourself and post your questions, or you can type it into the chat box. As of now, I've got one question from Dr. Rathan. What would be the cost implication of these devices? Yes, that's a very good question that is there. Kedar, can you take that one?
Thank you, sir, for your question. Sir, very sorry, sir. I'm not aware of the cost of the device because I should have seen it, but I didn't see it.
Yes, definitely. At the sense it is a new technology and still it is under development. Definitely the cost of these devices would be on the higher side. But as the numbers increase, definitely we will see it, just like with every other technology. We will see the prices of these devices coming down, and also implanting of these devices will be commonplace, not too far into the future.
Hello.
Yes, sir.
Good evening, sir. It's a
Good evening.
nicely presented. It's a new upcoming procedure topic. Now, just a simple question, sir. What are all the precaution to be taken if the patients of this device coming for thoracoscopy or laparoscopy because they inflate a lot of carbon dioxide and all? What are all the precaution? Just though cautery and all, just avoid about 20 centimeter avoid, so that will prevent the interference of electromagnetic interferences. So what all this precaution to be taken in the patients coming for laparoscopy or thoracoscopies? Kedar? Dr.
Yes,
Kedar?
sir. Yes, sir. Sir, as usual, we have to keep a check on the gas insufflation. The problem arises only in case of the S-ICD where there is a pulse generator, and the precautions will be same as we are doing with the patients of permanent pacemakers, which are present already. So there are no other guidelines apart from this in how to manage those situations. Just we have to keep a check on the insufflation. And then if their devices are leadless like MICRA and other Empower and Emblem, there won't be any issue because they don't have any external device or any
Yes.
pocket anywhere.
Okay.
And currently I saw the cost of the device online. It is 8.5 lakhs for MICRA.
Okay. So the battery is around 12 years.
12 years.
So
Sir.
whether the patient needs anticoagulation therapy after implanting, or there is no need till the endothelializations occurs?
That's also a very good question, sir. Yeah,
Good
that's
question.
from a practical point of view. Yes, so the
You
guidelines
said
stress that.
till it takes time for
Yes,
endothelialization to occur.
yes.
So
Just
till
like for
then,
all prosthetic valves, for this one also, the immediate post-op period of up to 3 months, we will have to continue with the anticoagulation
Okay.
as well as the antiplatelet therapy. And Kedar has rightly answered about the during thoracoscopic surgeries. Definitely for MICRA devices as well as for nanostim, definitely not much of evidence is there for thoracoscopic surgeries. And since it is an intracardiac device, unlikely for it to be of any
affected.
significance. But when we're coming to the subcutaneous
Yes.
SICD devices, definitely insufflation of the thoracic cavity where the device is implanted will definitely interfere with the functioning of the device, because there will be stretching of the electrode and the sensing electrode might come off the pericardium, and then it may not sense the arrhythmias within coming from the heart. So this is also just from anecdotal reports that have been there. Personally, I do not have any experience using these devices.
Yes.
It's only from the literature, whatever I have read. But I am not sure if there is any reported case for a patient who has a subcutaneous SICD who has come for a thoracic surgery.
Yes. But it's a nice, good tech. This one, if it is
Yes, definitely.
developed,
It's
wonderful
technology
because
and a
you can.
very good point that you have raised, sir. Definitely something that we have to be careful about. Any other questions from all, any of the participants, or any comments? Feel free, because this is a relatively new technology. Nobody is an expert on this one, so feel free to put in your comments.
So just like indication, is there any contraindication like?
Yeah, very
Dr.
good.
Kedar?
Kedar, can you take that one?
Just
Yes, sir. We had seen once. Just one moment, sir.
So yeah, one contradiction Dr. Kedar had mentioned during his presentation. Yes. So that
they
is
are contraindications to S-ICD system. They are anti-tachycardia pacing, bradycardia pacing, and CRT requirement.
okay.
So basically, if it's a pacemaker, it can only do pacing function. If the
Yes.
patient requires a defibrillator or anti-tachycardia pacing, then you cannot consider the leadless pacemakers at the present stage. But still, the technology is still in the developing phase, and manufacturers are working on both, combining the two devices together. So hopefully, in the future, we will see devices that will both pace as well as have anti-tachycardia or defibrillation facility as well.
So it is only can be used for adult, not for adolescents, and because what he said is 23 gauge sheath to be
Yeah.
used.
Yes.
So
Yes, right, sir.
for adolescents and pediatric, it cannot be
Unlikely,
used.
yes.
Yes.
Technically, it may not be possible. Not right now, I guess.
Mm.
So, Dr. Ratan, you'd like to make a comment on this one? Sir?
Hi, Anup, thanks for that. See, in case you're doing a laparoscopy or surgery, probably I think you need to place the concrete pad on the lower part of the body so that you can avoid the current going across the lead.
Yeah, yes.
Yeah, and short pulse bipolar would be ideal. In case you are using monopolar, then probably the returning pad should be away from the cardiac or the chest.
Yes. Yeah, Dr. Kedar had highlighted that. Yes.
Yeah.
This particular problem encountered especially in TURP surgery, TURP.
Yeah.
Transurethral, because only cauterization is the procedure, total procedure. So that.
Yeah.
So in URP, unlikely for it to produce because the circuit will be far away from the device.
Yes,
unlikely to be a problem in that case. So here issues will be only for thoracic surgeries or cardiac surgeries because it will be directly in the path, or upper limb surgery also for that matter, orthopedic procedures or neck surgeries, thyroid surgeries, mastectomies, breast surgeries. In such situations, we will have face situations, but surgeries involving the abdomen or below, unlikely to produce a problem if they have such devices in place.
Yeah. The other thing, query I had done is how much is the amount of current produced? Will we be able to see the spike created by the pacemaker on the monitor?
All right, very good, sir. Very good question. Yeah. So, yeah, Kedar, is there any mention of that one in the article?
Yes, he has mentioned electromagnetic interferences.
No. I think Dr. Ratan is referring to whether when we are monitoring the ECG, the spike will be visible in the ECG of the monitor. Isn't that right, sir?
Yeah, that was my query.
Yeah.
Sir, I think so. The ECG should show the spikes of pacing.
No. So that's only speculative because the article does not mention that particular aspect. So we are not actually sure about the intensity of current. I believe because it is directly implanted into the heart, the voltage that is created or the current that is generated is very much small,
low,
unlike the traditional transvenous pacemakers. So personally, I do not know whether it will create a spike in the ECG monitor.
Okay, yes, sir.
So whether it will interfere with the regular ICU monitoring.
Yes, that is something that we will have to personally use to find out. Yes.
Yeah.
That's why pulse oximeter is the.
Yeah, pulse oximeter we'll have to use. Yes. Any other comments or questions from the participants?
Regarding the use of induction of anesthetic agents, any particular drugs to be not to use or used, like
Kedar,
especially
yes,
scoline, especially scoline.
Right, sir. Drugs that cause any arrhythmia issues like ondansetron or metoclopramide, or again, as you said, succinylcholine. they should always be avoided. Just as a safety purpose, they have not been mentioned anywhere, like as an absolute contraindication. They have not been mentioned like that.
Yeah, I think scoring is more relevant when you implant it into the subcutaneous or muscle
Yes.
thing. Probably, I think here it may not be interfering as much because it is in the intramyocardial where the swelling doesn't act. And the other question I had was, if there is a need to remove the lead, how would that happen?
Yeah, same question. Because there is no duration, they are trying to put, but yet to remove the lead.
Yeah, they're not trying to get into that problem, I think.
So how to deploy?
Can you clarify your questions again? So what was that?
Anup, my question was, in case there is a need to remove the lead at a later date, would that be a feasibility? Will there be a issue? And I'm not sure whether that need would be arising as well. It's more of a hypothetical question at the moment.
No, actually, sir, that lead will arise, but after 12 years when the battery life is over, at that time maybe.
Okay.
So they might have come up with the solution of this, but I have not read about it. There must be some plan about removal also.
Okay, let us wait. We'll get more insight.
By that time it will be
We'll have to
totally
wait for another 10 years to know that, sir.
Yeah.
Okay.
Endothelialization, everything occurs. It might be difficult to remove.
Yeah, once it's fibrosed and all, yes, technically it might be a problem. So, is there further any comments from the participants? I don't see any more questions in the chat box. So, shall we then?
Yeah. I thank Dr. Kedar for the wonderful presentation of this new topic. Wonderfully presented the indications and the contraindications. Then intraoperative management, how to avoid the do's and does. I thanks Dr. Kedar for once again, and also I thanks Razi, and before that I thanks Dr. Murli Kanchi sir for make us to do much more day by day. I thanks everybody who participated.
Thank you, sir. I would also like to thank Murlidhar sir and also Anup sir for suggesting this topic to me. And I would also like to thank everyone who is present here.
Thank you, sir.
Yeah.
Thank you.
Thank you. Thank you, Kedar.
Thank you, everybody.